All right, guys, we're going to get started. Thanks everyone for being here. We're very excited about tonight's webinar entitled Bone Defects and Femoral Nonunions. I'm your moderator, Mitchell Bernstein. I'm a pediatric and adult orthopedic trauma surgeon, and I'm here in Montreal, Canada. Our faculty, amazing people, Matt Camuso in Maine, Chris Domes in Wisconsin. And these are both orthopedic traumatologists who are very thoughtful surgeons, and you'll get inside their head as they approach these femoral nonunions. We also want to welcome you to the AO Trauma North America Fellows webinar series. These are some personal photos from my AO courses. We want to tell you how wonderful it is. Come and join us, get involved. There's great opportunity for mentorship, networking. This is Keith Mayo over here in the blue shirt, doing some of his osteotomy planning. And then the other photos, myself with my co-fellows and Steve Benershka. We have some upcoming courses, 6 topics per year. They're going to cycle through different faculties and different topics, so look out for those. These are some of the webinars coming up throughout the calendar year. Managing soft tissue wounds, humeral shaft fractures, some pain management, deformity correction, and pelvis fractures. At the end of today's webinar, you should be able to identify sources of femoral nonunions and really identify what the risk factors were for this patient to have a femoral nonunion and potentially avoid those in the future. You'll be able to review steps in management of femoral nonunions, and we'll go over some pitfalls in management. We're going to have a very specific rhythm with these cases. So you're going to hear from Matt and Chris. They're going to go over a diagnosis, generate a problem list for each case, and then they're going to have a plan that follows the problem list. So we've been very strict to make sure that each lecture follows this cadence and rhythm. It's just an opportunity for you to see if you like that. You don't have to use that in your practice, but it's a way to come up with a diagnosis and force yourself to treat all the issues that are going on with the nonunion. These are all our disclosures. They were all resolved prior to our webinar. We have a Q&A box on the bottom. Feel free to ask us questions. We are live, and we are eager and excited to hear questions. And with that, we're going to start right away with Matt Camuso.
Morning, evening, guys. This is Matt Camuso. I'm one of the orthopedic trauma guys here in Maine. Sorry, we're just getting caught up. My job is to talk to you about the etiology and risk factors for femoral nonunions. We're going to try to make this as interactive as possible. We're going to make it kind of a round table discussion amongst the 3 of the presenters, but we want you to chime in and ask us questions as we go through. So please, please, please send in your questions and we'll try to answer them either live or via the text box as we go through. I think it's important for you to understand initially sort of how we think about and approach these issues. I don't have any relevant financial relationships to communicate to you with regards to this topic, but I will tell you that I haven't used BMTs in my non-union surgery in over 10 years. I just haven't found the need for it. I found other ways to manage non-unions using internal fixation, correcting alignment, identifying infection and metabolic abnormalities, and then generating stability with bone grafting using autograft in most cases. So many people, at least historically, as I was going through this, thought that BMP was going to be the answer for non-union surgery. But again, I have almost completely moved away from BMPs exclusively for only rare occasions. So my discussion here is going to start out with just sort of understanding the importance of a thorough patient evaluation to help understand the etiology of the nonunion. This is not the real sexy part of this discussion and talk, but it's super crucial to success in our ultimate goal, which is to attain union in femoral non-union situations. We're going to talk about classification as a way to think about why the fracture didn't heal and how it can help guide our forward treatment going forward, and then outline a systematic way to identify potential causes of non-union so that we can then go ahead and address each of those issues as we go forward. So when I think about non-unions, I think about the three factors, factors that are surgeon specific, factors that are patient specific, and fractures that are fracture specific. And these are obvious. The fracture specific issues can't be changed. They're related to the energy of the injury, the soft tissue trauma, and of course the contamination that's identified. Perhaps more important though, are to think about what the patient factors are. So what is it about the patient that is going to make their management of this non-union more challenging? Their comorbidities, what sort of diabetes do they have? Is it well under controlled? What are their nutritional abnormalities? Do they smoke, and how long have they smoked for? What sort of medications? And certainly then, of course, aggressive evaluation for infection. When I evaluate for infection, certainly there's a laboratory and a culture evaluation, but the most important part of evaluating for infection for me is taking a thorough history. You know, was the fracture open or contaminated? How many surgeries has the patient had before they came to you? How long did it take for their wounds heal? Did their wounds drain? Did they take long-term antibiotics afterwards? And then of course the other issues, including smoking, steroids, and immunosuppressive agents, all affect that patient's risk for having an infection and of course having non-union thereafter. This is a paper you probably want to read. It's by Mark Brinker and it's from the early 2000s. It's his evaluation of all the non-unions that he had seen up to that time in his practice that he had evaluated thoroughly with a thorough endocrinologic follow-up. And he found that many patients had underlying metabolic or endocrine abnormalities that were as of yet unrecognized. And he has this really complex algorithm that it takes people through, and you can feel free in your own time to look at this. But what it generally says is that there was quality reduction, quality alignment, and quality stability offered to the patient initially, and they still had a non-union, then you really got to think about an underlying metabolic problem. And so don't forget that these patients sometimes don't heal because of an underlying metabolic abnormality. Of course, other than patient factors, we as surgeons have a role in patient developing non-union. Of course, in open fractures, if we're not aggressive in our debridement and quality of doing so, they're at risk for having contamination and infection. We as surgeons can do additional biologic injury during the surgery that can cause stripping and of course non-union. But most importantly, and we're going to really focus on this today, is the initial alignment and stability achieved can have a real key role in whether or not that fracture goes on to heal. And so we as surgeons can actually prevent non-unions prior to them occurring. And that includes the list that you see here. So minimizing the additional biological insult. You see in this image here, 3 cerclage wires fairly closely positioned together. I don't have great disdain for cerclage wires when they're used ideally with minimal soft tissue stripping, but when you clump them together and strangle the bone, you can sort of understand how the biology may not be optimal here. Optimal fracture reduction and alignment, choosing the correct nail diameter, maintaining bone contact and compressing the bone when able, and certainly identifying risk factors and communicating those issues to your patient early on and intervening early on when necessary, are all ideally performed by the surgeon preoperatively. I find that actually evaluating the non-union early on, whether or not it's a hypertrophic, oligotrophic, or atrophic non-union, is helpful because it helps me understand whether or not that fracture needs stability alone, stability and biology, or an aggressive debridement. Certainly on the side of infection, if there's a sequestrum present, I'm going to have to be much more aggressive with debridement than in that patient that has perhaps a hypertrophic non-union. I break it down into a graph like this, where on the one side, infected non-unions are going to require antibiotics, culture, debridement, stability, and biology. What you'll see though, that's similar for all of the different types of non-union, whether they're infected, pseudarthroses, atrophic, oligotrophic, or hypertrophic non-unions, you'll see that stability is the key in every one of these. And so I've developed this checklist for all the non-unions that I take care of. I first try to classify it, and that isn't really, if you compare the way that I classify it to someone else, mine might say oligotrophic, others may say it's hypertrophic. It doesn't matter that you agree. It matters that you've looked at it and tried to classify it, because that tells you that you're trying to understand the non-union, why it happened, and then address those specific needs with regards to alignment and most specifically stability and biology at the non-union site. Of course, we also can't ever forget to evaluate for metabolic derangements and infection. And so in this particular case, we've got to look at this and say, look, I would call this an oligotrophic non-union. There's varus alignment. The stability is no longer sufficient, and maybe wasn't from the very beginning because there was such a small nail chosen. The biology at the fracture site is now compromised due to the surgeon iatrogenic injury. And of course, as a part of the evaluation for this non-union, I'm also going to check labs and cultures at the time of surgery to identify infection if it's present, and then consult with this patient to try to minimize their smoking and refer them to endocrinology if they have any sort of identified abnormality. So with that, I'm going to pass it on to Chris, who's going to talk to us about, once we've evaluated the etiology and sort of made a checklist, he's going to help take us through how to then manage that checklist and affect a surgical intervention to try to create union. Chris?
Great, thanks, Matt. Can you unshare your screen?
I sure can, sorry.
Oh, you're good. Okay, Chris Domes. So my objectives here are to review the options for the surgical management of these non-unions, review their efficacy, and then discuss the potential complications associated with them. These are the options that we're going to kind of briefly go over today. Really, doing nothing is always a choice. We have to remember this. You do need to document this discussion and have this discussion with the patient. It's really a great opportunity to learn the goals of your of care with your patient and really understand what they want, what they're willing to undergo. Make sure that they understand kind of the complexity of a non-union and what it might entail to treat it. And this is a great time, unless there's impending failure, really when you're discussing with your patient, to get second, third, and fourth opinions on how it might be treated, either by sending them to somebody else or you going and talking to your partners saying, hey, should we wait on this? This is what the patient wants. What can we do? But that's not very sexy, so we'll go to the more interesting stuff. Nail dynamization. What are we doing? We're taking a static nail and moving it to a dynamic nail. Matt just went over, stability is important. In nail dynamization, compression is what we're trying to get. So we're actually removing stability by taking away those static interlocks and allowing for the nail to compress. What generally it needs to be done at a more early stage when you're thinking about these non-unions. There have been papers that say that it can be successful past 6 months, but generally dynamization needs to be done earlier. The success rate, as you can see here in the papers that I reviewed, was anywhere from 20 to 80%. So it's not 100%. It does work, but not all the time. It is cheaper. It can be done on an outpatient basis even. But what are the complications? Shortening and instability. It's really important to see really where this is applied. When it's applied correctly, generally in a more diaphyseal or a apically stable fracture. So fractures that can compress against each other. When there's a significant amount of comminution, that might not be an ideal fracture to try to, non-union to try to treat with dynamization, because that might just generate too much instability. Nails generally like to be get compression with air. So it's also important, if you dynamize, you let the patient weight bear, because that's where they're really going to generate that compression through there. Next, we have the exchange nail. What is this? It's removing the old nail, reaming, and the goal is to upsize your nail. If you can get 2 sizes, that's ideal. You can also bone graft on top of this. There is some argument to saying that when we ream, we also introduce some of those good positive factors to the non-union site itself. But what are we really doing? We're increasing stability by increasing the isthmic fit. We know our nails are strong. You know, the strength of the nail is by the radius to the 4th power. What are we also doing? We're also stimulating perosteal blood supply. We do chowder up the endosteal blood supply whenever we ream. That's been shown. And so you are forcing some more blood supply to that periosteum. Timing can kind of be done whenever. The success rate is better than dynamization in general, but there are people that have shown to have less success with this, and that's going to be in smokers, in the setting of infection, and if there's a bone gap. When this is applied, generally you're dynamizing at this, or you're interlocking in a dynamic fashion as well. So you can also get some shortening in that fashion. Next, plate osteosynthesis. We're going to remove the old hardware. We're going to go look directly at the non-union. We're going to do a formal takedown and grafting, and we're going to apply a plate. That plate can be applied, you know, like a in compression. You can even put screws across the fracture and for lagging through the plate. The timing can really be done whenever. The success rate has been pretty good with these in the literature, and it has been shown to be slightly better than exchange nailing in the setting of infection. This is likely due to the ability to do a formal debridement of infected areas and really get control of infection with that means while looking directly at the fracture. What are the complications associated with this? It's more soft tissue stripping, which we of course know is bad. Higher rates of infection have been reported in plate osteosynthesis for these non-unions. You're going to have increased blood loss, and unlike nails, generally you have to restrict weight bearing afterwards after plate osteosynthesis of non-unions. Next, we have what I like to think of really as the kitchen sink, throwing everything at it here. Exchange nailing or retention plus plate fixation. So you can, there's studies that show that you can actually just apply a plate, and what's that doing? That's increasing the stability of the fracture non-union and trying to get it to heal. You can do an exchange nail at the same time, like I said, or good data says that you can retain your nail as long as it's not infected as well, and just plate on top of that. Timing can be done whenever. Good success rates have been reported. And the complications are really those associated with plate osteosynthesis. So you are going to have to do, visualization of the non-union, stripping, higher rate of infection, blood loss. In this, there's probably less of a need for restricted weight bearing, but that might also be a portion of your treatment plan. External fixation and llizarov fixation for femoral non-unions, challenging. It's technically challenging. It requires significant resources. Anybody who's had to deal with patients with ringed fixators on knows that it's a lot of calls, a lot of follow-up, a lot of checking pin sites. They have had decent success rate in the papers that have pushed for this, with both, as this paper in the JOT reviewed, broken plates doing corrections and fixation with the ringed fixator, did have good success with that. Time frame for this is really whenever. The complications is the big issue, as with the complexity of the ring fixator, not only applying it appropriately, but then you are constantly looking at pin site infections, deep osteomyelitis, and you're also putting a lot of pins through the quads and through the musculature of the thigh, which means stiffness can be an issue. Some of the more interesting things are really the adjuvant treatments. So bone stimulators, there's not a very compelling against bone stimulators. They have been shown to be effective. There's multiple different types. Direct current, low intensity pulse ultrasound has a fair amount of supportive literature on it. Some of the issues with bone stimulators is cost and also patient adherence, because the patient is doing this at home. In my mind, I think of these as really an adjuvant treatment. So it might not be the only thing I do, but I might stack this on top of one of my other treatments. Other places where it's been beneficial and definitely can have a setting is those patients who maybe don't want to undergo surgery, clearly want to try something, and then also the medically infirm patients. BMP. So BMP2 is off-label use for non-unions. It's approved for your tibia, open tibia fractures and your cervical and your spine operations. BMP7 has an exemption for long bone non-unions. You know, laboratory data is very exciting about BMPs, but like Matt said, it might not really be necessary. The real issues you have with it are the costs that can be prohibitive for some patients. Other things is that we don't really think about. There are significant potential complications such as renal and liver complications, as well as malignant transformation as you're this is an inductive type biology. Other things, stem cell treatment and platelet-rich plasma. These are options. There are papers on them. The big issue I have with most of the papers that say, oh, they're great, you can inject it right into the non-union site, it heals X number of weeks later, is in general, they're not very well standardized, both in the collection as well as in the centrifuging of the and precipitation of the factors that you are injecting and using in these non-unions. So maybe we'll see more of that in the future. It is out there. There is data that supports some of its use. There's also some data that refutes stem cell use. Really, the mainstay and gold standard is autograft application in non-unions. The gold standard place to take it is going to be iliac crest. There's a significant amount of research on the reamer irrigator aspirator, and that's just as effective as iliac crest. Wherever you take your bone graft, whether you use RIA or iliac crest, you got to talk to patients about that. They all have their associated morbidity. The one thing specifically when thinking about treating and taking autograft in non-unions is, at least in my practice, is you need to look at your non-union first and make sure it's not infected, or make sure that you're not going to have to change your intraoperative plan before you take your autograft. You can definitely get hosed if you end up taking your autograft, you go open your non-union and it's just pouring pus. Now you've completely sacrificed your autograft location and you can't use that. You can't, go back to that potentially later. So it's something to definitely think about is where am I going to take it? What positioning am I going to be in? What do I have access to? And then can I use it for this case at this time, or do I need to do something staged? So look at your non-union first if you're doing a non-union takedown and doing like an open plating, and then take your autograft. Some other things that are also kind of up and coming are recombinant parathyroid hormone, teriparatide. That's shown some improved fracture healing in atypical fracture patterns, and might be a further adjuvant that we're going to have a little bit down the line. Other things that we might think of as well are maybe potentially the sclerostin inhibitors. Research is ongoing in those, so I would stay tuned and just keep abreast of that, specifically to non-unions, if that's a potential option in the future. That concludes my portion of just going over the brief management. Next, we're going to kick to Matt for some cases.
Thanks, Chris. Really great point when it comes to the idea of looking at your non-union site before harvesting that bone graft. I do that 100% of the time. I open it up, I look at it. Look, I'm going to be wrong if it doesn't look overtly infected, but if it looks overtly infected, I will have saved that person a bone graft harvest. So great point there. So look, the rest of this is going to be cases, and we're going to try to show cases. We want you to keep asking questions. We've answered a couple, but we certainly expect more from you. This is a patient of mine. She's 79. I'm going to do all the old people. Chris is going to do all the young people. This old lady fell at home and has this injury. And when I look at this, it's looking suspicious. I'm looking at the edge of that femoral shaft. It looks a little bit widened on the lateral side. And so I sort of, my my ears are pricked up, and I actually go and look at her other side. It turns out that she had a very similar fracture on the contralateral side several months earlier, and had complained of right-sided knee pain in the last month and a half. In fact, even had a knee injection. And so you can see where this story is going, right? She had this atypical impending femur fracture that was unidentified. In fact, this was an x-ray from when she broke her other side. You can see her leg is in traction. Here it is about to break, but no one identified it. So again, prevention, right? So as surgeons, we've got to think about what the next injury is, what the next issues are, and this easily could have been prevented. This non-union that is I'm about to show you, had the surgeon simply identified it early. And so this is what the patient has performed. This is an cephalomedullary nail placement, and you can see some of the problems with this technique and why this may not have gone on to heal. Chris or Mitch, what comments would you make about this reduction, the alignment, maybe sort of the initial treatment of this fracture that may have minimized the risk of this patient not healing?
I think of that as, in my mind, it's a correct treatment applied incorrectly, as one of my colleagues would say. So I would probably treat this with a open reduction and nail fixation myself. I think this one has definitely a bit of a malreduction to it, and that's less than ideal and probably setting us up for where we're going to go.
Yeah, so clearly started varus, started to lateral, and then aimed to medial, and then as a result, you get this obligate varus alignment of the proximal femoral segment. Also, in these atypical femur fractures, the endosteum beaking doesn't just happen on the lateral side, it also happens on the endosteum. And so as one reams, one deflects out medially, and again, it turns into varus. So just as Chris said, I think an open reduction for these with me is classic, and whether or not you compression plate it or fix it with a nail is dealer's choice, but it's got to be sort of reduced and maintained that reduction during the application of the implant. And the predictable happens here, right? At 6 months, the implant fails because it's in varus and it's just constantly being torqued. So again, this is sort of the stepwise checklist for the non-union. The diagnosis here for me, again, I call this an oligotrophic subtrochanteric non-union. Others may call it otherwise, but at least helps me put it into a category that then I can start checking off the things in the problem list. I've got a problem list that's significant here. I've got a retained nail that's broken. The alignment is in varus and there's no stability present because the nail has broken. I know the biology here is poor, not so much because the surgeon injured it, but because of the bisphosphonates. I don't have any known overt signs of infection, but I do know that there are metabolic issues here with the patient's chronic bisphosphonate use. And so I create a plan similar to the way that Chris went through his identification of ways to manage this. And in my mind, the best way to correct this is by using a specific device called a blade plate. So for my plan is to take the nail out, correct the deformity, compress the fracture, provide compression, and then biopsy to rule out infection, and then finally to address the metabolic issues, knowing that it won't have an immediate effect, though over the long term it should stop the patient's bisphosphonates. And this has been studied. This is not the first time that we've seen this sort of malalignment after nailing of subtrochanteric femur fractures. And this idea of using a blade plate to compress the fracture into its more normal alignment, providing that absolute stability for this oligotrophic non-union, is really effective in these subtrochanteric fractures. And so in my practice, a blade plate is the ideal implant for this particular situation because you can apply compression with the articulated tensioning devices as well as with offset compression that you see here. In addition to that, in an effort to aid in the biologic sort of ramp up, is to do what we call a Jude osteoperiosteal decortication. This was described by Jude back in the 60s.
I was raising my hand. You didn't see me. I was raising my hand.
You need to speak up. Go back.
Can you go back a slide?
Yeah.
There's a question. When do you? This applies to obviously the entire webinar and non-unions. When do you do a? You're going to talk about the Jude decortication. When do you do a formal debridement, quote, takedown of a non-union, and when do you assume the tissue in there is osteogenic and just not touch it? When do you excise the tissue? How do you know that preoperatively? That was one of the questions. That's a very good question.
That's a great question, and I don't know that I have a perfect answer to it. I definitely think that if you look at a non-union and it is hypertrophic, it is trying to heal. That non-union rarely needs to be taken down. It never ever needs to be taken apart. It just needs stability. It needs to have compression. And so taking that hypertrophic non-union down is never necessary in my mind. If there's clear infection or sequestrum present, then that always needs to be taken down, right? And then there's a whole host of ones that are in between. And I think you have to use your better judgment. If your suspicion of infection is low and you can correct alignment without having to take down the entire non-union, then you don't take it down. If the infection suspicion is high, then you're going to take it down and investigate it really aggressively. Or if you have to make an alignment correction, then taking down the non-union may be necessary. So in those two situations, I think for sure I would consider taking it down. But in the hypertrophic situation, I wouldn't take it down at all.
So it's an art. In summary, it's an art is what I'm hearing from you. And for us learners, we're trying to come up with our own algorithm. I think it'll be good just to listen to Chris and Matt as they go through the cases, and you'll hear what they were thinking and when they indicate the patient for a takedown or not.
Yes. So in this particular case, as I approach and expose this non-union, I'm going to be in it. So I'm not formally taking it down, but I am going to do what I call or what has been described by Jude as a decortication of the periosteum. And that's a pedaling of the cortex in leaving the soft tissues attached to that very thin cortex of bone all the way around the non-union. It essentially creates a new injury in the non-union site and acts like a local bone graft without actually harvesting and doing a bone graft. And so in this way, I'm affecting not just the stability by compressing across the non-union, but I'm also creating a local bone graft by doing a osteoperiosteal decortication. And in his series of over 1,000 patients, it was unbelievably useful. This was before RIA, this was before BMP, it was before the sort of novel, neat ways that we now harvest bone graft, and he had unbelievable union rates. And so this has been very useful over the years, and I think for many of us has become more commonly used in these sorts of situations. And so in this particular situation, doing the combination of generating compression as well as improving the biology by doing a decortication has resulted in a fairly rapid union over a period of 3 to 6 months. Chris, do you have another case?
Yeah, I do. Let me pull it up here. And Matt, just a quick question. Are you getting endocrine involved in any of your people that you're dealing with, especially with those atypical femur fractures or non-unions? Are you, what other specialties do you get?
Yeah, I have. Yeah, so for bisphosphonate patients, I definitely get them involved, not so much because they're going to fix their bisphosphonate poisoning, but because they probably would benefit from being on an alternative agent, right? And so I'm not an expert in that, and so I really want them to be on board to say, look, they've been on bisphosphonates for now too long, but they still are breaking. What are the other options for this particular patient? And so they can weigh in with some authority on that with my patients.
Yeah, that's great. So my case here, so we have a 15-year-old. Once again, all I do is work on young people who don't heal. So they had a right open femur fracture, a left closed femur fracture, and unstable pelvic ring injury. Let me see here. They underwent bilateral integrated intramedullary nailing that were statically locked. We used pediatric nails given her age and size. And then because of the pelvic ring, we had to delay weight bearing for about 6 weeks. At 6 months though, left side feels great, pelvis feels great, right side continued thigh pain. So really at my point, I'm looking at this 6 months in. To me, this appears to be a hypertrophic non-union. So I'm breaking down now my problem list. I've got my retained intermedullary nail. I think my alignment's good, but my stability, as I'm classifying it as a hypertrophic, is poor. So I've got a stability issue in my mind. The biology is questionable though, given it was an open fracture, possibility for infection. And then as always, I always look for metabolic issues, vitamin D, and then also nutrition, albumin, things like that. So when I'm looking at this, I'm thinking about my plan. What am I gonna do? I'm gonna do my workup for infection, and I'm gonna do my vitamin D, make sure that's all good and our albumin's all good. The bone ends look like they wanna heal to me. I wanna increase the stability of this non-union. What are my options? Exchange nailing, compression plate fixation. I think it's too far out for me for dynamization. So really what I'm looking at are those things. So what do? I'm trying to increase stability, lag screw fixation around the nail. Little curveball there. So percutaneous small incision, direct lag screws across the fracture, changing the microenvironment of that fracture non-union by just jacking up the stability. 10 months
Are we
out.
allowed to do, Chris, are we allowed to do shout outs?
I guess so.
I just want to shout out to my fellow at McGill who told me about this concept, and I was like, what are you talking about? So it's a very cool concept, Chris. Okay, I'll stop talking.
That's great, yeah.
So just to be clear, Chris, it's a hypertrophic non-union that needs compression. And what better compression method do we have than a leg screw, right?
Exactly
so why
right.
wouldn't it work, right? If you actually are following the sort of AO basic principles, this is right out of that principle manual, right?
Yep. You give it what it wants, and that's what we did here. So at 10 months, she's gone on to heal. No thigh pain, doing great. This isn't just going off the deep end here. This actually has been published in Tips and Tricks, or Technical Tricks here, the percutaneous strain reduction screws by Robert Handley's group, the Bob screw as they might be also referred to. There are some prerequisites though, of course. The fracture needs something is one of their prerequisites, which is kind of funny, an obvious thing, but it's in the prerequisites. You need to have a satisfactory reduction and good alignment. So you're not going to change rotation with these at all. You're just going to increase the stability there. The non-union plane, of course, has to be amenable to lag screw placement, and there has to be the absence of infection. In their original paper, they go over about 33 people, and they do it across wide different locations of these non-unions as well. And they found it to be very effective with about 92%. So I think they had, out of the 33, they had 3 persistent non-unions, which needed something else. But all of their patients really satisfied all the prerequisites and came out with a good, somewhat less invasive option for treating their non-unions. Interesting case. Matt, I'll kick one back to you.
Super. All right, so I've got
an epic case, Chris. Epic case.
Yeah, elegant, super. They're like very straightforward and a really nice, elegant solution. All right, here's another old person from Maine. She's 70. She fell from standing. I think she was walking around her pool. She normally walks around pretty well. She's a smoker, and she's had some knee pain prior to this. It's unclear as to whether or not this may also be an atypical femur fracture, but we managed this with a straightforward closed reduction and retrograde nail placement. You might look at this and say, man, you did pretty good. And that's how I looked at it, because I did it. I thought that was pretty awesome. But as I look at it afterwards, I sort of look at it critically and say, okay, this distal femur fracture has only 2 interlocking bolts in it. It is in a distal segment where there is no good bone contact between the nail. So I wonder what's going to happen to this person as she starts walking. Can anyone predict? Anyone predict what's going to happen? Think about what's going to happen here. Well, I let her walk like we do all femur fractures. She's got a little bit of a varus femur anyway, which makes me think maybe she's got a little bit of sort of strange metabolic derangement ricket situation going on. But I didn't make much of it. We just let her walk on it, and she got around okay. But as you might have predicted, she has ongoing pain over the next 3 to 6 months as she shortens and collapses into varus. And so if I were to look in the mirror and say, hey, Camuso, what did you do wrong there? I would say to myself, boy, I wish I had gone back and put a stupid blocking screw right here to prevent that thing from falling into varus. And I might have prevented this non-union from occurring. However, here we are. We don't have that luxury now. And so in answer to that question that the fellow posed earlier, here's an alignment problem. We're in varus. We've got a nail in place with a broken interlocking bolt. And so we've got to create a problem list. We've worked up her for infection. It's clearly not healed, but there's no other evidence of infection from at least a laboratory and bone scan evaluation. So as I look at this, my diagnosis was that this is a fracture that's trying to heal. It's hypertrophic, but it just can't do it because we didn't provide it with enough stability. But now I've got this problem list that I've got to take into account to try to manage the non-union. We've got a retained broken interlocking bolt and a retained nail. We've got varus with some still retained stability, but it's not ideal. I think the biology here is good. There's no reason to think that it's not, other than the potential for maybe being infected, that this was a closed fracture. But again, I'm really suspicious about this lady's biology. And so I think we did get her to see the endocrinologist to evaluate. We tried to get her to stop smoking, but we also sent her to endocrinology to see if there was any other issues that we needed to address. I believe that she did have vitamin D deficiency, but that's all we found. So our plan, as based on our problem list, was to remove the interlocking bolts from the distal femur, correct the alignment, and retain the nail in this particular case. Now, you could do this in a variety of different ways, right? It's a hypertrophic non-union, really just want to get more stability present. So you might say, well, I'll just do an exchange nail. I felt that that would be hard in this particular situation, so we did it a little bit differently. We worked her up from a metabolic standpoint. We biopsied the non-union site at the time of surgery, and again, we got her to stop healing. And this is what we did. So in one particular way, we actually used a lateral plate and screw fixation construct that we could tension that would both correct the varus as well as compress across the fracture site while maintaining the intramedullary nail. And the reason that I did that is because I didn't want to just leave a lateral tension plate without a medial fixed buttress. I felt like that might just fail at the plate itself. So retaining the nail in this situation was chosen so that we wouldn't collapse into varus, but it also was used as a tool to try to compress across the non-union site. Mitchell.
Question, is this similar to the banana phenomenon?
Well, that's how I thought about it when I considered the ways to manage it, right? I knew that I had to correct the deformity. So removing the nail and sizing up the nail and trying to put a blocking screw in, that might certainly have worked. But removing the nail and simply try to compress on the lateral side without having an intact medial column, for me, was a banana waiting to break, right? So that's what I was worried about in this particular case. And so in this way, a little bit more of an elegant way of doing it without violating the knee once again, maintaining the nail, and then compressing using this device without really doing a big aggressive open exposure.
So there was a first that you answered a question about nail plate combos. This would be clearly amenable to primary treatment of a patient, you know, with that technique. Would it be a nail plate combo with comminution on the medial side?
What do you mean primary treatment? Like the initial treatment of the fracture?
Yeah.
Or?
Yeah. If you had a fracture, you know, there's a lot of trauma surgeons doing nail plate combos for femur fractures. Sure. Would you consider that this patient could have had that in retrospect as a primary treatment?
I don't think so, Mitchell. If I look at this, you know, there's this sort of medial butterfly. I don't know that I would have put a plate on the medial side of that. I think, though, that I might have considered using a blocking screw right here to prevent that from falling into varus, but I don't know. Now, I will say that in more distal fractures and then more distal metaphysis, that I might I might consider plate nail combo, because that's even more likely to fall into varus. But in this particular situation, I think for me, if I were to, have 20/20 hindsight, I would have put a blocking screw in there. How about you, Chris?
Yeah, I agree. I would not go right off the bat in this fracture pattern to a nail plate combo. I'd primarily do what you said and do what you did and nail it. One of the other ways of treating these non-unions for an intervention is the addition of puller screws later though as well, which could have been done as you kind of see this starting to drift if you catch it soon enough. That's one of the things, if you don't catch it soon enough, if the cat's already, the cows are already out of the barn, it's too late. But it has been written up as well, the addition of puller screws to increase stability. So what are puller screws? Once again, they're essentially blocking screws around the nail to decrease the motion of the nail. That maybe, if caught soon enough, could have done it, but then we wouldn't have such a great case.
I was not smart enough to have caught it. I wasn't smart enough to catch it early, but this was an effective treatment. But it's just a sort of a different way to provide compression across a hypertrophic non-union, right? And so it's no different. It's just it still is the same concept for providing additional stability for a fracture that's trying to heal. And so this is how it turned out. I mean, it felt immediately better to the patient. She was able to immediately weight bear, and within 3 months she was comfortably walking once again. So sure, is there another way to manage that femoral non-union? Absolutely. But doing so this way followed the principles that we all have talked about, and was an effective treatment in the long run.
And Chris, you corrected the deformity. I mean, that's...
And so correcting the alignment, huge. Right? Getting her out of varus, which was
mechanical
a
access.
part of that.
Yeah, absolutely. Yeah, I'll pull up another one here. Continuing on with young patients that don't heal. This time we got an 18-year-old, so bumping up a couple of years. Another polytraumatically injured patient, right open femur fracture, right closed tibia, traumatic brain injury, liver laceration, otherwise healthy guy. Initially went intramedullary nailing on post-injury day 7. This was after damage control orthopedics because of his head bleed and other issues that we had to take care of more pressingly. He did have a debridement at the time of initial X6 placement. We then did his up-down nails and we protected his weight bearing for a couple weeks. At 16 weeks, continues to have some ongoing thigh pain, see some fluffiness around the fracture. But at this point, 16 weeks, still early on, this is looking concerning to me, and I would say this is early oligotrophic femoral non-union territory. So I'm thinking, do I need to do something? My problem list, I've got my retained nail. I think my alignment's okay. My stability, I think, is okay. Biology is definitely questionable because of the mechanism of injury and the open fracture. And then with that comes the concern for infection. And then we always don't know metabolic disorder until we start screening people's vitamin D at random. So I drew some labs. Labs were unconcerning. He did have a low vitamin D. I was like, well, that's something I can definitely correct. Though, based on how this is looking, I wanted to do a little bit more. I wanted to change the strain environment at the site. Also, given the fracture, I thought, hey, maybe we can see if it's infected, and then we'll start replacing his vitamin D. So at 16 weeks now, I opted to do nail dynamization and started the patient weight bearing. You can see it's placed in the right portion of the dynamic hole. That fracture, that proximal segment, is going to compress against the distal segment, which is statically locked. The distal segment is statically locked. This is dynamic. The proximal segment is dynamically locked. That nail will go deeper into that proximal segment, causing compression at the fracture. We let him weight bear, but then, 3 to 5 days later after doing the operation, 1 out of 3 cultures comes back positive, staph epi. That's a big question. Is it a contaminant? Is it not a contaminant? We decide, though, to really start and kind of treat this more aggressively with some IV antibiotics. I get my infectious disease colleagues in tow as well. And we decide as a group to really kind of treat this. Though we treat him with antibiotics, we retain the nail, which you can kind of discuss as was that smart or not. But at 32 weeks, okay, we'll give it a little bit more time. 40 weeks, still hasn't healed, still having high thigh pain. You can see though that, you know, the interlock proximally did move. He did compress, and he also changed his fracture. What does he have now? He's got it looks way more hypertrophic to me than really oligotrophic. Now I'm starting over though. It's still not united. I've got my retained intermedullary nail. I think my alignment is good. I think I have insufficient stability. The biology is still definitely at question. Does he have ongoing infection? He was on suppressive antibiotics for 6 months at this point. And then did we change his metabolic state with his vitamin D? Once again, his concern for infection, even though we retained the nail, is still low. Normal ESR, normal CRP, normal white blood cells after being off of antibiotics for a period of time. His metabolic disorder with the low vitamin D, we were able to improve. So right now I've got a hypertrophic non-union. I do not think it's infected. I am not sure with the previous positive culture, but after a period of time and an antibiotic holiday, still normal labs, no signs of infection. I want to change his environment, change his hypertrophic non-union. I need to jack up the stability. So,
hey, Chris.
Yeah.
Chris, there's a question about how to assess for infection. Do you ever do white blood cells per high-powered field like they do in the joint world, or is it mostly just sort of looking for overt signs of infection and then taking lots of cultures and then following them up reliably and then treating them if they're positive? What are your strategies?
I take lots of cultures. I've definitely had cases where I thought, man, it would be nice for high-powered field cases. I have not done that yet. I generally just am extremely meticulous in the cultures I take. If it doesn't look overtly infected, well, if I'm very concerned for infection, I actually do a lot of non-unions in a staged fashion. So if there's a nail in there, I'll do an antibiotic rod for a period of time and then come back after I'm sure that there's no infection. So I'll wait 3 to 5 days for my cultures to pop. If they're negative that time, I'll do a definitive surgery.
Okay.
With increasing
so you
stability
sometimes will stage it. And is there something that ticks you off and says, I got to stage this one versus, well, I think I can get away with not?
Initial injury, so initial stripping, the look of it in the setting of more of an atrophic or an oligotrophic, I'm more likely to think about doing it in a staged fashion, like you discussed already. In hypertrophics, I think they just want stability. They want to heal. They just aren't in the micro strain environment to allow for that. But
right.
really,
so you use radiographs and you look critically at the patient, take a good thorough history, and that really is important in your decision as to whether or not you're going to stage them or just go for the home run.
Yeah, very much so, because I mean, the staging is not, I mean, staging sucks, right? Anytime you have to reoperate on somebody,
no patient wants to be staged.
No patient wants it. And it's painful, right? Because you're taking away whatever little stability they had potentially for a period of time. You can use, antibiotic coated plates to give them some stability, unicortical plates or something like that. I use a lot of antibiotic coated rods because I want to generally treat as much femur as I can. If I am concerned that there's infection, I do open big takedowns, and if it's really infected. But yeah,
okay, great. Yeah, that was a question. I just wanted to make sure that got answered.
Yeah, no. So in this case, though, it looks hypertrophic. If it looked atrophic or even more oligotrophic, that's one that I would do a more radical debridement and likely stage at this point. But with this, if we go back, this to me looks hypertrophic. It's trying to heal. So our plan, increase stability. Nails are great for really giving that, axial stability and bending stability. Not so great in torsion. So we add a plate on top of that. So we actually did a nail exchange, reaming nail exchange, sent those reamings off for culture, left it like your last case. It's dynamic. It's not locked at the bottom. So it's giving me some stability by increasing that isthmal fit with a bigger nail. We were able to jack up the nail by 2 sizes. I'm still getting that bending stability with the nail in the middle, but then I'm also adding a plate, compressing through the plate, and that plate is really going to help resist some of those torsional forces that fracture might have been seeing, that plate might not have been sufficient to really take care of. And with this kind of, full court press, nail plate combo, we were able to get him to heal, doing great, pain-free, doing a lot better. That's my case. Matt, do you have another one?
I do, Chris, but I think what I might have you do is just go to the pitfall slide since we're running up against time. Yeah. It's about 8:55. And then maybe we'll have Mitchell sort of give us a final complex case that will give us a nice summary and then some take-home points. Does that sound good, Mitch?
Yeah.
Okay, let me reshare my screen here. So hopefully we've shown you guys some cases here that kind of, get the blood flowing to the brain, thinking about these non-unions. So some of the pitfalls that we specifically wanted to point out where you can make mistakes are really at the beginning, and that's not obtaining a thorough history of the index fracture, the whole post-operative course. You have to identify those small things like, oh yeah, it was red and really tender, and I went to my PCP. I never went to my orthopedist to, find out if they had some indolent infection, which might still be smoldering in there. You gotta find those small details to change things in the next kind of evolution of taking care of these. So really, perioperative history of infection, extremely important. The nature and the severity, the soft tissue stripping that was initially there, critically important. And then you really need to look at modifiable patient factors: smoking, vitamin D, poor nutrition, obesity, even mechanics, all things you need to look at. And then some of the pitfalls are not addressing malalignment. If you're going in there, we know that mechanical access is very important. Address mechanical access, improve mechanical access can also improve fracture healing. And then not providing adequate stability or compression at the fracture site. We're cranking it up. They've already gone through one operation. Stability, stability, stability. Do the best you can to change that microenvironment to increase the stability of that fracture. Non-union. Okay, next I will pass it over to Mitch for some closing remarks.
All right, we're gonna pick a case here. I'll ask Matt and Chris to choose. We have one case left, and then we're gonna shut her down. We're gonna try to stump Chris and Matt here. Matt and Chris, what do you guys think? What are you guys in the mood for? What do you guys think? What do you guys think? What are you guys chuckling there on mute?
You're muted, Matt.
Matt, yeah, I really need to see an osteosarcoma.
I do too. That looks so interesting. Let's look at that osteosarcoma case.
I'm glad you asked, guys. I'm glad you asked. Okay, so this is a recent case that I had. I thought it would highlight some of the points that we've been making here today. So here we go. So I'll fast forward through the history. So this patient had a distal femur osteosarcoma that had a resection, limb salvage, physeal sparing, and had a allograft. That allograft failed. It was a medial approach, as oncologists do. That failed.
Does that ever work?
I think that's beyond the scope of this lecture. I'll move on to the next one.
I actually, because of this case, looked that up. 10-year is decent. It's not great.
Getting off topic here, guys. I'm the moderator. We're getting off topic here. The Q&As are pumping in. They're red hot now. So 3 years post-op, this is how he presented, and it was revised to dual plating resection of most of the allograft. Some of the allograft that was incorporated was left in, and then massive autograft bone grafting into the defect. And he was doing okay until this slide. So what strikes you here, Matt, on these X-rays as you work this up for non-union clearly?
Well, I see loose fixation laterally, I believe. I see bony overgrowth of the plate proximally. I see valgus, significant valgus present in the distal femoral segment. And, you know, the intercalary bone looks mottled and unhealthy, as it commonly does when it's sort of a masculate technique, which I think that that's what this is. And I wonder if it's got like a canal. How healthy is it? I don't know. Is it infected? All of those things are coming to mind. Like, I'm worried that this is just one big pus pocket.
Okay, so it's not infected. You get a CT scan.
Yeah, I love that. I mean, I love that. So that intercalary segment actually looks like it has a canal, right? And it almost looks like there's just a fairly simple non-union in that distal metaphysis there, right? Now you've got deformity to deal with. You've got a strange bow, and that's going to make it difficult to negotiate. But it does look like a fairly straightforward non-union in that distal third, along with a malalignment problem.
So now, you're talking about the local environment. Now we have our standing hip to ankle X-ray. So we're assessing alignment here. He's 4 centimeters short. He has distal femur valgus, as you mentioned, and now you can quantify that. Again, this is beyond the scope of this lecture, but that's another deformity concept. So you can quantify the valgus. So Chris, who do you call? Who's your go-to mentor with these cases?
Well, my senior partners, and really with all the cases, I can't thank, my senior partners enough for bouncing off of those. I'm relatively only a couple of years out into practice, and having people to ask about these tough cases, the treatment options can't be underemphasized. I like to ask 3 to 5 people, and that way you have a majority rule type way of taking
so an odd number of people.
Exactly, yeah. Right, because you ask 2, it's like it's 50-50. I ask odd numbers of people so that there's always a tiebreaker.
Do you have?
I think when you have those multiple opinions, don't you find that they're all addressing the same things from a sort of basic sort of foundation principles, right? They use the principles maybe in a different way. One may say put in a bigger nail. One may say use 2 plates, but both are trying to get at the stability issue, right? Yep. One may say correct the alignment in this way, and others may say correct, but they're usually talking about the principles the same, and getting addressing those principles may be a little bit different. But that's what I find when I ask, and I'm like you, I always ask for opinions when I'm faced with difficult problems. That usually they're different a little bit, but they're usually similar in terms of how they're thinking about the principles for the solution.
Yeah, very much. I mean, if you get somebody who's kind of off in left field, that's why it's good to have some other people to talk to too.
No, I apologize to you, So Matt, because Chris and I are, I mean, it's understandable that we'll ask people. Do you still have mentors, Matt, that you ask advice on, colleagues?
Oh yeah, and it's not just mentors; it's better colleagues, right? I mean, it's my junior partner and it's my senior partner, and it's my joint partners that used to do trauma. I like to get input wherever I can, and so I certainly have been in the situation where I haven't thought of a particular option, and I'm embarrassed to say that I didn't think about it in that way, and we decide, boy, that would be an elegant thing. The second case that I showed was the intramedullary nail, and I think I showed that to my partner and said, I'm just going to exchange nail it. And he and I said, what if we just compression plated this on the lateral side? That's what it looks like it needs, right? And so you could do the other thing, but this would be a nice, elegant way of managing this. Let's see. And then actually I did it with him. We did it together. And so you know, that becomes even more fun and more rewarding and more of a learning experience when you're doing those cases together with your partner. If you can find the time, if you guys can figure out your schedules, it's a little bit easier where we work because it's not quite as busy as some other places, but it is very, very nice to be able to get into the operating room with one of your senior partners, especially to do a case together, because you learn from one another constantly throughout the case. It's remarkably fun and really rewarding to do.
Problem list. He's 2 years post-op. He's 16. He's now skeletally mature, so it's a bit of an opposite of a problem. He has osteosarcoma resection. He's failed an allograft. Then he's failed the distal aspect, then failed with a masculate type, although it wasn't, you know, it didn't have a cement spacer, but massive bone grafting, has a distal non-union. He's got a 40 millimeter limb length discrepancy coming from his femur. He does not have rotational alignment, malalignment, so that's an opposite of a problem list, but nonetheless on our list. He's got valgus in his right distal femur, which has been quantified. We rule out infected non-union. He's got retained medial lateral plates with, I think there was about 17 broken screws in here.
All from the medial side too.
Medial and lateral. So yeah. The plan was dual approaches, remove all the hardware. And I had 3 hardware removal sets that day. We're gonna debride the non-union site. So in this case, I wanted to physically get in the non-union site. I wanted to debride it for a biologic stimulation, but also to obtain cultures and pathology. In addition, because the valgus correction would occur through the non-union site, I needed to mobilize it. We're going to use a retrograde Raffin. I think it's important, and I don't think it's silly to actually talk about the implant you're going to use, because they have their certain locking options and radius of curvature. So we're going to use this device with a anatomic LDFA of 84 degrees in the distal segment, and that should realign the mechanical LDFA to 89. We're going to put blocking screws in the distal segment. That's been discussed to increase the stability and also to obtain and maintain the alignment. And as Matt said, we're going to recanalize the IM canal through this masculate stupid bone, which in and of itself was a discussion with some of my colleagues and mentors. And a backup is going to be a clamshell explosion osteotomy to just explode the entire segment. We're gonna do number 6. We're gonna get this non-union to heal, and then we're gonna redo the proximal osteotomy in virgin bone and lengthen with an internal lengthening nail. Issues: bone stock and distal segment. Chris Dome's question.
Yeah, Mitch, what are you planning on doing in one day? Is this all in one day, or are you planning on staging this?
Yeah, it's all one. Well, this is all.
I mean, you've got bails, you've got stop points, right? I mean, you always have stop points in cases. If you get in there, it's full of pus. You know, you're stopping.
Oh yeah.
With taking your hardware out.
But he looked very, very. There was really no history of infection. His wounds were all healed, but it was more of a histologic. Does he have one of those non-unions? There was not pus pouring out. And that was Matt discussed. You know, does he have a sinus? Is the wound open? Is there cellulitis? It was completely dry, no history of that. And then there's a deformity in the sagittal plane, so there's a relatively straight nail. So we're planning emotionally for a backup second osteotomy. So intraop, again, this hardware removal took about 2.5 to 3 hours. We do it very carefully. Try to not remove bone stock as you take the trophines. So we took all the hardware out, took the tissue for culture. There's no signs of pus material coming out. It ended up being aseptic. So from the medial side, we're mobilizing the non-union. Again, we're aiming for this target LDFA. So we're just playing around with the C-arm and drawing some angles to make sure we have the right trajectory on the AP, right trajectory on the lateral in the distal segment. And here's our blocking screws. So we're going to put an anterior blocking screw to prevent recurvatum and a lateral blocking screw to prevent this valgus, as this is in the concavity of the deformity. In our reamer sets, we know we have 6 millimeter hand reamers, so we're trying to perforate the canal and recreate the canal. We had to perform a secondary osteotomy to negotiate the curve of this bone. We ended up getting 84.2, so we're off by 0.2 degrees. But we got a nice alignment, and now we just got to do a lengthening. So
Very
I'll pull
elegant.
up my.
Well done.
Yeah, that's a master level course or non-union right there.
Am I still sharing here? No.
Nope.
We see your face. We've just got a couple minutes. There were a couple questions that came in that I suppose I've answered, but I think they are worth sharing. And one of the questions is good. It says it seems like the majority of time we're aiming to increase stability at the non-union site. It doesn't seem like we run into a situation where we've added too much or inappropriate stability and we have to make it less stable. Is that a true statement? Do we see that ever? Do we ever see situations
I don't think that's First of all, I think that's a very cool question. I think it's very cool. And we are talking about femurs. So I think each non-union has its own personality. And most of the fractures we've shown were diaphyseal lesions. And I think you showed a distal. Did you show your distal femur, Matt, with the plating? You didn't get to show that. Sure. So they're mostly diaphyseal lesions. So with that, I don't think we had the opportunity to cause too much stability and increase the strain at the fracture site, but that is theoretically possible. Again, if you have the appropriate fracture plane, if it's a simple fracture, and if it was overly stabilized, yes, that could go against the AO basic concepts.
Yeah, I would agree. I mean, I think we see not uncommonly in simple, for example, fractures of the distal femur, they get a very rigid plate and locking screw construct applied with a small gap,
Short,
right? And
yeah.
so that's way too much stability, and that fracture has enormous strain and won't heal. And so, in that case, you're right. There's too much strain. That might have been a fracture that was more appropriately treated with compression plate fixation, with more traditional implant. So I think it can go both ways, just as you explained, Mitch. The other question was, how do you make sure that you've got the right stability? I guess it's the art of surgery, but are there any perfect guidelines? Is there some length of plate I need to use, or certain diameter of a nail that I need to use, or what are the things that you guys like to lean on for those?
My understanding of that is fracture surgery. That is fracture surgery, optimizing the environment and obtaining the correct amount of stiffness. I don't have an answer for that, in short.
There's some literature that would suggest with isthmic fit matters. Some say a 10 nail is good enough for everything. Now we're lucky in the femur that fundamentally it's encased by muscle, it wants to heal. That's why we don't get, especially with shaft fractures, 98% of them heal. In shaft fractures, there's some decent data that says really you want a lot of isthmic fit, so upwards of 90% isthmic fit. If you have less isthmic fit than that, there's a higher chance for a non-union, so 70% isthmic fit is a number that's been reported in a pretty reasonable paper from about 2015. That's one way I think about it. So I try to get a larger nail, even though some of the data would say a 10's good for everybody. I kind of like a lot of isthmic fit with my nails in that type of fracture, in a diaphyseal type fracture.
I think you got to break it down. You have to be thoughtful. You have to ask colleagues. You have to be really critical, and then use, unfortunately, some of your experience and try to explain what happened to optimize the environment. And we talk about stability and alignment because that's critical. All right, that'll bring us to our take-home messages. Non-union surgery is challenging. It's very challenging. I have to tell you, it's amazing. It's amazing surgery, extremely rewarding, but very challenging. You have to pre-op plan. You have to ask friends and colleagues. You have to prepare for this stuff, but it's really challenging. You do stick to the basics. I mean, some of you may or may not have taken the AO basic course, but it's applied principles, non-union surgery. I think, and I think Matt and Chris alike as well, generating a problem list, and then it forces you to address each issue. And again, this alignment and stability concept is critical. Assessing alignment and addressing it, and assessing instability and addressing it. So throughout the year, there'll be upcoming webinars. Take a look at AO Trauma North America and subscribe to its YouTube channel. You can, there's a lot of great educational material out there. We appreciate your attention. Thanks for the great questions, and thanks for being here, guys.